So let's take a look at the venous system. And remember, I think the best way to do it is kind of remember the veins that don't match up with the arteries. Like there's no carotid vein, just like there's no jugular artery. So can you see my white? Let me do this. I'll go into a slideshow. Maybe that'll help.
Yeah, we can see your cursor.
It's white though, right?
Yeah, it was white.
I think I like the black better. Now I'm gonna go back to the other one because I can make it bigger. As long as you could see it. Now it's black, and now it's white. It's white when it's over the model. Okay. So let's think about this coming back. So this is a really good inset here because you could see the major veins. There's no other way to get in the right atrium except for the coronary sinus. So remember that. This is a question I'm going to ask on the practical and the written part. There's three main ways that deoxygenated blood or less oxygenated blood, remember 75% oxygenated blood gets into the right atrium. And one of them you can't see in this picture. It's the coronary sinus. The coronary sinus is only a vein, and it's draining the myocardium of the heart, posterior. So know that coronary sinus is probably an identification too. So that's one way deoxygenated blood gets into the right atrium. The other ways is the superior vena cava, which is above the diaphragm, and the inferior vena cava, which is above the diaphragm. And I really like this picture because then we can go from there. The bottom, this is the bifurcation of the common iliac veins. We're talking about veins now, and you have to write vein or artery on the practical. You really have to do that. You'll lose points because there's going to be the abdominal aorta taking blood away from the heart with the right common iliac artery and the left common iliac artery. So you got to be careful where it's pointing to. So now we're draining back to the heart. Veins always drain blood back to the heart, whether they're systemic or pulmonary. You just have to know if they're oxygenated or deoxygenated. And only the pulmonary veins are oxygenated. It's the only place you're going to see that besides fetal circulation. So the blood is draining back from the legs via the left common iliac vein and the right common iliac vein. And it's coming back, right? This is a vein, systemic vein, deoxygenated, and veins always bring blood back to the heart. So it's all inferior vena cava. Of course, there's going to be a lot of branches joining this vena cava between the bifurcation and the diaphragm. And this is tricky here. The blood draining back from the arms and the head. So there's a right brachiocephalic vein draining into the superior vena cava and a left brachiocephalic vein draining blood from the left side of the body, left arm and the head, and partly upper torso too. So this is a good picture to see where the main branches of veins are draining back to the right atrium. Superior vena cava and inferior vena cava, the major passageway into the right atrium. I know I keep repeating that, but it's worth it. Okay, and now as far as the matchup, the companion, I think your book says companion vessels that are arteries, there's no brachiocephalic on the left artery. It's just the brachiocephalic trunk, which branches to the right common carotid and the right subclavian and the right vertebral. So it's kind of an asymmetry up here, right? Here's the brachiocephalic trunk, that little aortic arch branch. And this is the left common carotid artery. And this is the left subclavian artery. This is the ascending aorta. So there's not really a companion for all of these. So this is a really good picture to show you that. And if you look at the picture, the big guy, right in here, you could see the superior vena cava, and you could see the left brachiocephalic vein and the right brachiocephalic vein. And down here on the bottom, you could see everything from the legs is going into the left left common iliac vein and the right common iliac vein to the inferior vena cava, or cava, however you like to say it, whether you're from Yonkers or the Bronx, you probably say it different. Okay. So let's start at the bottom. I think because that's going to be the pathway, and see how these veins match up close up. So now the tissue of the feet have been oxygenated. All the cells have received their oxygen. They're able to get oxygen into their mitochondria, make ATP, and have all those muscles function, and all the skin go through their cell cycles. But now we talked about venous return. We have to get that blood back to the right atrium through venous return. You should know all the ways that venous return is accomplished, because there's no pressure in the veins, right? All the pressure is in the arteries. So if you look at the lower leg and go through your checklist, I might be telling you more than you need to know, but look at your checklist that I have on Blackboard, and you could make sure you know all of those, be able to identify them, which will be really easy, right? So you have your anterior tibial veins, and you know where the tibia is from A&P1. So you know that's the medial bone, and that's in the front. The anterior tibial is in the front. So, you know, when you go through APR and the atlas, online atlas, you get a lateral view too, so you could see that the posterior tibial vein is behind the tibia. So that's a good one. Anything and you have companion arteries for them. I'll mention that as we go. Then as you get behind the knee, now patellar means anterior knee. Popliteal always means posterior knee. So anything that's pointing to an artery or vein, which have companion arteries and veins, is going to be popliteal in the knee. And you'll see that there's nothing else to name actually in the knee. Then you have this posterior medial vein. It's on both sides. I might have mentioned you use this for grafting, for cardiac bypass, coronary bypass artery surgery, where you bypass the coronary arteries that are occluded, and you take a piece of the great saphenous vein, which looks like it has a lot to give, right? I mean, you can take a piece of this, nobody will miss it. You know, you take a piece of great saphenous vein, you resect it, and then you take that great saphenous vein tissue and you plug it into the aorta, where the blood is nice and oxygenated and flowing freely, and then you plug it back into the myocardium, so the myocardium can get blood directly from the aorta. So you bypassed the clogged coronary arteries. I mean, we got to go back and fix them or put stents in them to keep collateral circulation going, but you could use this venous tissue. Yeah, there are valves in the great saphenous vein because you have to keep it flowing in that one-way direction. So the great saphenous is the big one. I mean, technically, this is called a small saphenous, but don't worry, you could say great saphenous. What's so great about it? I really don't know. It's long. That's why they call it great, probably. And then you have other branches coming in here from the tibials through here. And naturally, if it's along the femur, it's going to be called the femoral vein. And there's a deep femoral vein. So know that separation here. Femoral vein, bigger, more centrally located, a little bit more medially located, I should say. And the deep femoral vein, more on the femur, draining blood from the osteocytes and all the tissue within the femur and around the femur, deep femoral vein. Okay, so you have companion arteries there. And then as you go up higher, above, draining back from the femorals, again, all this tissue is bringing back carbon dioxide, waste products, break down urea, all the things that go in there, water, everything. And then it bifurcates, of course. But before that, you have to know that the internal iliacs are here. And that's a companion vein with the artery as well, internal iliacs. And these are external iliacs. So if I point right here, that's left external iliac vein. If I point right here, that's right internal iliac vein. Looks like there's no median sacral vein like there is an artery, median sacral artery. So that kind of hangs down here. You should remember that. Median sacral artery. But there's no companion vein in this picture anyway. Okay, so that's pretty much to the vena cava. And then you're going to have your gonadals, which are companioned with the gonadal artery. So your gonadal veins draining back from the male testes or the female ovaries. Again, vena cava. And then there's a portal system we talked about coming from the intestines to the liver. So that you have to basically know what's going on with the portal system. And then you have your renals. The kidneys aren't here, don't forget. So draining blood, and these are really important vessels here because the kidneys have filtered all that oxygenated blood. And the parenchyma, which are the active cells of the kidney called the nephron, need blood supply as well to function because all those tubules of the simple cuboidal tissue and a lot of hormones and crazy stuff going into the kidney. So you have to drain the deoxygenated blood from the kidney via the renal veins. So they have companion veins, and I will ask those. Still, right here, if I point here, it's still the vena cava, right? It's still inferior vena cava, right? It's still inferior vena cava. The only superior is up here, that little piece. Then you have blood coming back from the liver, not the portal veins, but the hepatic veins that are draining the parenchyma of the liver. Parenchyma means the functional cells. So they're called hepatocytes because anything that's called hepatic means liver. And you have some other branches, of course, from the pancreas and draining blood from the stomach. So that's pretty much the overview of this more superficial. Now you're going to see veins behind the heart we have to talk about in some upcoming pictures. Okay, so let's drain blood from the brain now. So draining blood from the brain, you don't have to know too many of these. There's a lot of branching of venous system and arterial system. So there's no circle of Willis in the venous system. That's arterial. Circle of Willis is to do with arterial blood going to the brain from the heart and bringing oxygenated blood, because this is systemic circuit. The only contradiction you're going to see is in the pulmonary circuit. So we're draining blood from the head and then face too, right? And you have the external jugulars, right? External jugular and left external jugular. And then you have the internal jugular, which is really coming more from the brain. The external jugular is coming more from the drainage of the facial muscles and the skin of the face. So internal jugular, I think that's the horror movie one. But you're better off, if you're making a horror movie, you're better off slicing up the carotid artery because that has more pressure, right? If you cut the jugular vein, you might have a chance. Horrible thought, but it's just less pressure, right? In the jugular vein draining back to the brachiocephalix. So basically, that's all you need to know about the brachiocephalix. Yeah, brachiocephalix, left brachiocephalic vein, right brachiocephalic vein. So you don't have to mention, like if you're taking blood back from the brain, you don't have to mention the subclavian. You just go right from the jugulars, external and internal, into the brachiocephalix, and then into the superior vena cava, and then right atrium. So let's go to the arm. Let's see what we got. So this model, this cartoon guy, he's in the anatomical position. That means his thumb is pollex, digit 1 is lateral, digit 5 is medial, and his hand is supinated. Means his palms are facing up. That's anatomical position. Because if he pronates this, then his radius is going to rotate over the ulna, which is medial. The ulna is medial. The radius is lateral, just to review that if you don't remember. So radius bone, lower arm bone, is on the thumb side, on the pollex side, in anatomical position, but it radiates. So you have to say anatomical position so you know your point of view. So you have your palmar venous arches, which are draining the hands and fingers, and go through your checklist, see if you have to know anything more, and we'll go through it in this PowerPoint. So the radial veins are going to be, right radial veins are going to be on the thumb side where the radius is. The ulnar veins are going to be more on the medial side where the ulna is. Then we have the median cubital vein right here. That's a good picture of it right there. It's kind of deep. When the colors get a little lighter, they're deeper, lighter purple as opposed to stark blue. So median cubital vein, this would be a good one to do an injection or draw blood because there's low pressure. So we don't want to draw blood from an artery just to get a blood count, an assay. But the only time we want to take blood, this is important, the only time we want to take blood from an artery is when we're doing arterial blood gases, when we're looking for absolute levels of oxygen or oxygen saturation of hemoglobin, right? Or how much carbon dioxide is in that arterial blood, because that's important. Because we don't really care about the veins. The veins aren't going to the tissue. They're coming away from the tissue. So arteries are delivering the goodies, especially oxygen, to all the tissues, especially the brain. So we could puncture the median cubital vein and then take blood at relatively low pressure. Now, if somebody has really high blood pressure, it may affect your venous system, but for the most part, it's okay. So if somebody has really low blood pressure, it may be hard to get blood. Or some people have weak veins where they collapse very easy. So if any of you are talking about being phlebotomists, you have to find the vein. Sometimes you have to occlude the arteries and get some blood to kind of pool up a little bit so you can pop the vein out and then poke it. Right? Here's where it gets a little dicey sometimes with students because you're used to that brachial artery with its companion brachial vein, and it does have a companion brachial veins, right? There's two. So be really careful here. So this is the way I would do it. Know the most lateral one, and that's the one I'll ask you too, especially. The cephalic vein, which has no companion artery, is a thicker, deep, lateral vein, draining blood into the right subclavian or left subclavian, depending on what side. So you have the basilic is the most medial, pretty much between the biceps and triceps muscles. So it's medial. So median cubital, then you have cephalic, which is draining back lateral deep. The basilic, which is coming in medial deep, and the brachial veins along the brachium, which is anterior humerus, really. There's a humerus behind. Now, I have to tell you, veins aren't the same in everybody. Like some people may have thicker brachial veins than they do cephalic. Genetics, maybe, other environmental things, the way you exercise. So it's not exactly the same. But this is textbook, and that's what we're learning, and your questions are coming from McGraw-Hill textbook, right? So learn the textbook way, and then maybe ultimately, if you're doing angiograms ultimately or Doppler ultrasounds, and you're looking at these things and looking for anterograde flow as a radiology tech, then you'll know, well, it's a little different. And now Miss Jones's, brachial vein is really not that big. And you can see that there is slight differences. But again, this is textbook stuff. So the brachial vein has a companion artery, but the cephalic vein does not. So I'll ask cephalic vein because it's only a vein, not an artery. There's no companion. So then we get up into here, and all these veins, like the basilic, is going to drain into the axillary vein. So be careful here. Depends on where I point. I'll be as clear as possible. Now look, this is the head of the humerus, and the glenoid cavity basically makes up your armpit, and that's the axillary region. So this is, I would have to point right here for you to say axillary artery vein, but this is the right axillary vein, and there's a companion artery, and then left axillary vein would be here, just adjacent to the shoulder joint, which is the armpit, and this is the left cephalic vein here. Both draining both the brachials drain into the axillary. The cephalic drains directly into the right subclavian vein. So see under the clavicle, is it always like that? No, but there it is. So anything above here is subclavian vein, and that drains directly into the brachiocephalix. Same thing on the side. Axillary into the subclavian vein, which drains into the left brachiocephalic vein to the superior vena cava. Yeah. So take a look at that and go through your checklist, and we'll see if we can get a little deeper. Here's the arteries, which we did. I'm not sure if we did the circle of Willis, but let's go through this. I'll put this picture on. Now, ultimately, this is the inferior view of the brain, and we're going back to arteries now, and they are red because they're systemic. The systemic arteries are oxygenated, so therefore they glow red because of the hemoglobin saturated with oxygen. So this is basically your circle of Willis, but you need to know the attenuate or the incoming arteries as well. So the vertebral artery is the arteries right and left, and this is the bottom of the head. So this is anterior, and this is posterior. So this is the right side, and this is the left. But you won't have to name right and left so much on this picture. This basically gives you the circle of Willis inset. So the two main, well, there's actually four, but the two coming up through the transverse foramen are your vertebral arteries. And then you go into an artery that's kind of one artery. It's not paired, called the basilar artery. So that's bringing in a lot of blood to this circle of Willis. The vertebrals branching to the basilar artery. And the other two are, and it doesn't even tell you here, these two, this one here and this one here, these are your internal carotid arteries. Internal carotids right here. Oh yeah, it does tell you. I'm sorry. Internal carotid. There you go. Sorry. And then you have your anterior cerebral artery, and then your middle cerebral artery, and posterior cerebral artery. So you have to know this is anterior. That's a big help. Then you'll know that this is the anterior cerebral artery. And there's a middle, and then there's posterior. And these are, yes, internal carotid arteries. I didn't see that up there. So this is, I would know all of this. I'm not going to ask you about the pituitary gland or the optic chiasm, olfactory bulbs, but this is right where the circle of Willis is, just below, ventral or inferior to the optic chiasm, which is just above the pituitary gland, and the hypothalamus is deep or superior. You have your mammillary bodies. So this is feeding the left and right side of the brain, technically. And this, if you have an occlusion in any of these arteries, like the middle cerebral artery, you're going to have infarction of brain tissue, neurons in the right side of your brain. And that's called a stroke, a cerebrovascular accident. If there's an occlusion, a plaquing, could be a thromboembolism. And you should be able to follow that back. I probably wouldn't make you go as deep as the middle cerebral artery, but the internal carotid I would, because you know that one. Right? So if you have a clot that starts in your leg, right, in a vein, right? Let's picture this now. You have a clot, a thrombosis or a thrombus that starts in the deep tibial vein of the right leg. You have to, and thrombosis is a blood clot, or a deep vein thrombosis. So if a piece of that thrombosis breaks off, it's called a thromboembolism. And that's going to further occlude vessels above that. So now you have to do the whole path from the deep tibial to the femoral to the, you could skip the external iliac. You can go to the common iliac vein, right common iliac vein to the inferior vena cava, up into the right atrium to the, through the tricuspid AV valve, to the right ventricle, through the pulmonary semilunar outflow valve, into the pulmonary trunk, into the lungs via the pulmonary arteries, which are deoxygenated, and you can get a pulmonary embolism at that point if that embolism clogs one of the pulmonary vessels. But let's say it doesn't. It comes back via the pulmonary veins to the left atrium, goes through the bicuspid valve, or AV valve, also known as the mitral valve, into the left ventricle. Now, this is a really important part right here. So the left ventricle pumps blood through the aortic semilunar outflow valve into the aorta, right? So the aorta has two branches just superior to the aortic semilunar outflow valve, and that's your left and right coronary artery openings. So if that embolism gets into one of those vessels, left or right coronary artery, now we're in the coronary circuit, and that's going to go to the myocardium of the heart. And if it occludes one of the big vessels, like the left anterior descending artery, you're going to have myocardial. Well, first you're going to have ischemia, which is lack of blood flow. Then they're going to have injury, which is falling. Basically, the proteins are falling apart because they have no oxygen to contract, and they can't depolarize. And then you're going to have infarction, which is death of the tissue. Myocardial infarction, could call that a heart attack now, right? And you can see that on EKG. If you look at an EKG, you're going to see a change in that QRS complex, specifically for that area of the heart, which could be inferior lateral, which is really important part of the heart. That's where the muscle is. That's where most of the left ventricular systole comes from. So you're going to see an EKG change in that specific part. And what you see is ST elevation. ST segment elevation will show you a myocardial infarction that's acute. They call that a STEMI, STEMI, ST elevation myocardial infarction. So you know it's acute, you know it's transmural, I mean it's going through the entire wall of the left ventricle, which is a really important place, right? To get oxygen to your tissue. So yeah, that's the way you look at this. Now, of course, the thromboembolism may have not gotten into the coronary circuit, and then it continues up, right? It continues up the aorta to the aortic arch. But what if it gets into the brachiocephalic trunk? Now it's on its way to the right side of the brain, right? Right, correct, right side, correct, right? So now the thromboembolism is going up through the brachiocephalic trunk and may get into the right common carotid artery. And that may go into the right internal carotid artery, which is going to make its way to the circle of Willis on the right side and cause a cerebrovascular accident by causing ischemia to the brain on the right side, injury to the neurons. They stop working. They're trying to rely on anaerobic respiration, and then they'll infarct. They'll actually die. And that is a stroke. That's a cerebrovascular accident. So if it happens on the right side of the brain, it's going to affect the left side of your body. Maybe paralysis, maybe complete numbness, maybe lack of vision. Depends on what part of the brain is affected. All right. So we just followed an embolism from the leg all the way to the brain, and you picked a side too. So that's the kind of question I will ask in that ordering. Okay. So know the flow of blood. And then we mentioned all three circuits. I mentioned the systemic circuit because that's where it started and ended. We had to go through the pulmonary circuit because we had to talk about pulmonary embolism, and we went through the coronary circuit because we had to talk about the coronary vessels being occluded. So know that pathway in the anterograde flow. Anterograde is one way, helped out by venous return. Because if it goes backwards, let's say one of the valves is insufficient, you're going to have retrograde flow, which means there's backflow. So I'm going to ask you backflow all the time. If I'm going to say, okay, so what if the aortic semilunar valve is insufficient or stenotic or prolapsed, which means it's just not working. Stenotic means, stenosis means a small hole, like it's not wide enough to fill or get the blood out. It's like a decrease in lumen of a structure, is stenosis. Prolapse means it comes out the wrong direction. Like an umbrella on a windy day that kind of opens inside out is what a prolapse valve would look like. And then it could just be insufficient, where there's too much connective tissue or infected, rheumatic heart disease, or just too much crap, too much atheroma, too much cholesterol, too much LDL, too much macrophage, too much fibrin. And there's conditions that affect the valves specifically. Or you could have a condition called atrial fibrillation, which you may have learned in lecture, which is an arrhythmia where your atria is going nuts. They're just depolarizing 10 to 1 to the ventricular output. So that causes a lot of problems, especially if you have tachycardia, right? Heart rate, ventricular heart rate above 100. So you kind of have to put all this together and take a look at that. And remember, when you have atrial fibrillation, the AV node is saving the day. So you could have a normal heart rate. You might not even know you have atrial fibrillation. Atrial fibrillation is a massive depolarization of the atrial cells, but the ventricle cells are depolarizing normally. So the QRS is normal, but there's no P wave, right? Remember the sexy P wave? There's no sexy P wave. It's a horrible line. It's jumping all over the place, but the AV node saves the day and you get good ventricular output. Okay. Any questions on that? That flow of blood is really important. I know I did that, but I'm recording, so you can always go back, drink a Red Bull, whatever, and go for it and learn it. All right, so it's all there for you. Let's see what else we have. Other veins and arteries that I didn't really go through last time. So circle of Willis. What you talking about, Willis? So go through that. And here's a lateral view, thank God. So you can see a little difference in the draining. Here's your thyroid gland. So you have a branch to your thyroid, draining the thyroid, which is chock full of thyroid hormone. So we got to get those hormones into circulation. So here's how it happens, right through the superior thyroid vein into the internal jugular vein. And then ultimately, we'll get into the left ventricle. You got to remember how that works. External jugular vein, lateral. So the internal looks bigger, right? That helps me remember, and it usually is like that. And here's the vertebral vein, which is off of the draining back to the subclavian. This is the right side, right lateral view. So the vertebral vein has a companion vertebral artery going through the transverse foramen of the cervical spine. Remember, the cervical vertebrae are the only ones that have transverse foramen, and this is why, because the vertebral artery and vein will traverse those. I'm sure you don't have to know too many of these. You probably should know the facial vein draining the facial muscles. And there's maxillary, retromandibular means behind the mandible, which is the jaw, is the angle of the jaw. Occipital veins, this might be a little too much, but again, if it's on the list, you need to know it. And it makes sense. Superficial temporal, draining blood back into the internal jugular. But these three are really important. The external jugular, the vertebral vein, and the internal jugular vein. Remember, jugular is only vein. There's no artery. That's carotid. So if you're lost, at least you'll know this is the thyroid. You know that the thyroid is draining back to the internal carotid vein. Right? This is more the deep in the brain, and you should know the superior sagittal sinus. Again, we don't do neuro. We did that last semester, but the cerebrospinal fluid is reabsorbed back into the blood system via the arachnoid villi into the sagittal sinuses. So the sagittal sinus, superior sagittal sinus is probably the one I would ask. And there's an inferior just above the corpus callosum. And occipital makes sense. And straight sinus is right in between. Transverse is lateral. Sigmoid sinus is pretty much on top of that thick, draining that. That's a pretty big sinus coming out of the brain to the internal jugular. So I would know the superior sagittal sinus and the sigmoid sinus. And see what else is on a checklist for that. Make sure I don't miss the veins here. This one's kind of tough. This is where it gets a little goofy. So let's learn the ones here. And it makes sense. I mean, you know all this now, draining from the head and arms. And then you get into the thoracic. And this is kind of asymmetrical, like right and left. So if you see this one on the right, this is important. I would star this one. It's the larger draining vein of the thoracic and all the mediastinal contents, intercostal muscles, all that. So the big one is called the azygous vein. So I would make a mark on that one, azygous. And off to the left is a smaller accessory. And this is not always the same in everybody. You have the hemiazygous. So the hemi means half or part of. So the azygous is the big one, more paravertebral to the right in this patient. And then the hemiazygous to the left. And you see the vena cava. Epigastric is going to mean the above the stomach, epigastric. So you have some more new ones here. And there's the median sacral that wasn't on that first picture. So there it is, median sacral, which has a companion median sacral artery and median sacral vein. Lumbar veins through here. This is where it gets a little tough, because now you're going to have to enter into the portal system as well, hepatic portal system. I like this. Look at this. Shows you everything where it's draining. And it really is ultimate places are inferior vena cava and the superior vena cava and the right atrium. Because don't forget about the coronary sinus. Is this on this picture? It's not really on this picture. Coronary sinus is really important. Back to the arterial blood, which you should feel pretty comfortable with. Celiac trunk, we went through that last time. Branches of the celiac trunk is only a arterial system. Big branch, right? I think it's the first, it is the first branch below the diaphragm. But it's going to branch further to your gastric, your splenic, and hepatic. Celiac trunk branches. So here's your branches. So this is an important slide. The branching. Here's your mesenterics. We went through that. And let's get to the veins. Here's your hepatic portal system. So here is the liver. First of all, know the liver. This is that stupid, ugly, bile-releasing gallbladder here. Here's all your intestinal tract. Really what they're showing here is that they took away the small intestine for the most part. There's not much small intestine. So you have your inferior mesenteric vein draining blood back, right? And here's your hepatic portal vein coming back. So all the intestinal veins will, like superior and inferior mesenteric vein, will dump blood, drain blood into the hepatic portal vein, because the liver is a massive manufacturing center of hormones and enzymes, storing glucose in the form of glycogen, clotting factors. A lot of things are going on here, building, detoxifying. So anything that you eat has to go back via the portal system. All those macromolecules, amino acids, monosaccharides like glucose, your fatty acids, lipids, even nucleic acids have to go back to the liver to either be detoxified or built into a new molecule. So the portal system is the way that goes in there. So it's not oxygenating blood. This is not the lungs. So then it's going to leave the liver via the hepatic veins to go back to the vena cava and be put into circulation, because those hormones got to be used for something. So ultimately they have to go back to the left ventricle to be pumped into the systemic circulation, to the brain and the lower body as well. Sorry about the dog barking. So you go through, I don't remember, looking at this one, I don't know how important the, going down to the umbilical arteries on your checklist. So, okay, and here's the arteries of the arm. Most of them have companions, except for the cephalic, right? A little different in the brachial area, right? So you have different, compare these two. There's no companions to cephalic vein, right? So these are two to keep going back and forth. Make sure you know where the cephalic vein is, a median cubital, and your basilic vein are. Here's the legs, which we did last week, and close up of the legs. Compare. There's no great saphenous artery. You have pretty much companions except for that. for the most part, the great saphenous. And dorsalis pedis was the artery. And in the veins, is dorsal venous arch. So that's the difference. Plantar, arteries and veins, companions, right? Fetal circulation, look at the list. You should know what the ductus arteriosus is versus the ligamentum arteriosum, right? Because again, the fetal circulation in a fetus, you know the story on a Friday night where the sperm meets the egg and in the fallopian tube, and then it forms one nucleus, it forms a zygote, which implants in the uterus, endometrium, and then you become an embryo for 8 weeks, and then after 8 weeks, you become a fetus, and then you stay there for a good 32 weeks before out you come. All right. So fetal circulation, you don't need lungs. You're using mom's placenta, right? So you're getting oxygenated blood via the umbilical vein from the placenta from mom. It's only mom, right? So there's actually blood passing between the left and right atrium, right? So there's oxygenated is mixing with the oxygenated blood. So, and also there's blood mixing between the pulmonary trunk and the aorta. So the foramen ovale is a hole that should, of course, it's not there in an adult. In a fetus, is a hole between the atria and the ventricle. I'm sorry, between the right atrium and the left atrium. Of course, that becomes a fossa after birth. So you should know that. Let me see if the ligamentum arteriosum. So yeah, this is the ductus venosus. You should know that. Maybe we'll get a picture of that somewhere. Here it is. So the ligamentum venosum, or the ligamentum arteriosum, this is between the aorta and the pulmonary trunk. It's a ligament in post-fetal, after you're born, but it's actually a duct before that. So that's called ductus arteriosus in a fetus. So that it's allowing the deoxygenated and oxygenated to mix between the pulmonary trunk and the aorta. So of course, after you're born, it becomes a ligament, connective tissue, ligamentum arteriosum. So those are big ones. So fetal circulation, you can see like the ones that are highlighted are important. Umbilical arteries, ductus venosus by the liver, and then the foramen ovale, it's not a fossa ovale in a fetus, and the ductus arteriosus, which is not a ligamentum arteriosum between these two vessels in the adult or after you're born.